Hello and welcome to ASCP's Best Practices in NSCLC Biomarker Testing video conference series. Today's session focuses on actionable results and turnaround time indicators for NSCLC workflows. My name is Dara Oken and I'm a learning experience designer at ASCP, and I will be facilitating today's session. Copy of the disclosures can be seen on the screen. Today's session is developed through a commercial sponsorship from Genentech. This ASCP Genentech initiative is aimed to support anatomic pathology managers and their teams to build community and provide effective resourcing to drive biomarker testing continuous quality improvement on behalf of patients. Please note that this video conference is being recorded, and by participating, you are agreeing that ASCP may use the recording of your image and statements on ASAP's website. So before we get started, let's take a moment for introductions. Please type in your name, title, and institution into the chat. Great to see so many of you here so far. As you're introducing yourself in the chat, let's do a quick recap from the first video conference in the series, which took place in November. The NSCLC related topic was standardizing protocols for optimal procurement, fixation, and tissue cytology rows specimen handling with Dr. Lonnie Yarmus and Dr. Zara Maleki, both from Johns Hopkins. We've taken recorded highlights from the presentations, including innovative approaches practiced by the team at Johns Hopkins, and posted them in our Facebook group and resource hub with questions to delve in deeper, as shown here on the screen. The presentations are complete, but the conversation can be ongoing, and we hope you join the conversation to extend the learning experience and sharing dialogue. Well, the emphasis of this initiative is on application, focused on perspective of the lab manager. At the November session, we split into breakout groups after the presentations to address obstacles as well as paths forward in standardizing protocols in your own lab context. This word cloud illustrates the topics that were discussed by participants in those small groups, and you can find notes from those discussions which have been posted in the Facebook group. In addition, if you missed the November session and you would like to watch the video in full, you can find it at the ASCP Resource Hub. In November, we introduced the Action Plan, an individualized companion to the video conference series. This tool is designed to assist you in improving your NSCLC biomarker testing processes and workflows, and to help create a clear path for attaining patient-centric goals. So you have the documents intended to help define the goal, steps to achieve it, while exploring barriers and moving beyond those obstacles, all while tracking your progress toward your goal. Maybe you've already started your action plan, and if not, today's presentations and discussion could help you solidify a direction to take with your individualized goals. In the chat, you'll find a link to the action plan, and we will also provide the same link in the post-conference survey. Today, we will hear from Ms. Kimberly Brinkley, Assistant Vice President of Molecular Pathology Operations at Path Group, and Dr. Michelle Schiller, Associate Medical Director of Genomic and Molecular Pathology Services at Path Group and Medical Director of Cancer Genetics at Baylor Salmons Cancer Center. Ms. Brinkley will share her expertise on pre-analytic lab processing considerations, and Dr. Schiller will share on the analytic phase. We'll have a brief Q&A following the presentation. And finally, we'll separate into breakout rooms where you will have an opportunity to actively participate in small group discussions related to applying best practices. Same as last time, we will capture highlights of ideas generated in note form for the Resource Hub, as well as continue the discussion on our Facebook group. A few final reminders. Before we start, please keep your microphone on mute until you raise your hand and are called on to speak during question times. Also, please do not share any protected health information or personally identifiable information about patients. Now let's welcome Ms. Brinkley and Dr. Schiller to today's NSCLC video conference. I'll turn it over to the presenters to share their slides and begin.
Thank you so much for welcoming us, and thank you everyone for tuning in today. It's a pleasure to talk with you today about actionable results and turnaround time indicators for non-small cell lung cancer. I know this is something that we are all dealing with, especially non-small cell lung cancer, as kind of the example as to where these roads are going to go with all the different targeted therapeutics available in all kinds of cancer types. So I also want to let Kimberly have a hello out to everyone. So you want to say hello real quick, Kim?
Yeah, good afternoon, everybody. I'm happy to be sharing a little bit of my information on the day-to-day processes here at the laboratory at Path Group. And hopefully we can have some discussion and learn a little bit from each other as we move through this presentation today.
Excellent. So the first thing we will show is that we don't have any disclosures that should be impacting anything we're going to discuss with you today. And then we'll move on to starting with pre-analytic considerations. And we know there was a talk in November, and so we're trying to kind of maybe revisit and kind of pick up from where the prior talk with Dr. Yamas left off. And so, you know, what the next kind of thing, we now have tissue in our hands, and the big question is, what do we do now? There are all kinds of things that can be done to help optimize successful outcomes. At your individual institutions, there are the key players of people who manage the tissue. There's the people, like maybe you have interns and residents at the institution, or nursing staff, etc., who brings tissue to the lab. So it's important to have SOPs for them, and maybe have training sessions on some regular basis, or have a way for nursing staff and ORs to train new nurses and let them know where we keep our fixatives, especially for those specimens that may come in after hours. And you know, even maybe where a second container would be, should it be a busy night in the OR when there's no one there, and the normal fixative that's more readily available is not full. There's other things like what type of fixative. The most common, of course, is neutral buffered formalin, and most testing is validated on specimens that have received neutral buffered formalin as a fixation. Recording fixation time is also important. While we think about this probably with breast cancer, and it's more scripted there, fixation time does impact the downstream success of testing. The cold ischemic time is particularly negatively impacting the ability to get good sequencing data, due to the fact that the DNA starts to degrade readily once it's cut from its blood supply. Decalcification simply cannot be sequenced adequately because the acid breaks the DNA into fragments so intercalated that you can't align it effectively. So important to also kind of have a plan if a decalcified specimen comes in, how we're going to manage that, especially if we know it might be something that may be subject to testing downstream. Other things that can be done when there are multiple passes done on a patient, putting the tissue pieces or fragments into different blocks helps to optimize spreading out that tumor, especially as the tumor may be distributed in a different three-dimensional arrangement in each of those tissue fragments. One thing we did at our institution at Baylor, I don't know, a long time ago, it's been easily 9 years, is we started cutting unstained slides at the time at which the specimen came into the lab. And whenever there's a lung nodule biopsied, it gets labeled special handling. This is before we even know whether or not it's an infectious process or a tumor. So any lung nodule biopsy gets labeled special handling, so that once after it's been fixed and it gets cut that initial time, we cut 15 slides, and 1 in 15 get stained, and then we have 13 unstained slides to work with. That helps to, increase the utilization of the tissue without having to go back into the block and refacing. It's also important to have an established protocol for downstream testing of specimens identified as non-small cell lung cancer. And there's data to show that patients who have reflex testing, one, get more frequent consideration of targeted therapeutics, and two, are more often put on a targeted therapeutic. So, it is a best practice to have reflex testing and some sort of method for that, but it does require a multidisciplinary dialogue with the other stakeholders in the process for the patient. Minimizing immunohistochemical stains used to establish the diagnosis to the extent possible. I certainly know that as pathologists, we often operate in a vacuum, unaware of all the other background history, et cetera, for a patient. So we do need to be mindful of that, but trying to optimize it, especially if you really think you're dealing with a lung cancer. And I can't emphasize enough the value of clear communication between the relevant parties. This is definitely a multidisciplinary, many parties, and not even multidisciplinary amongst the clinical colleagues, but within all of the people in the lab, from the person who records and accessions the specimen to our histology lab who's cutting the tissue, to the gross submission of it, et cetera. Every single person has an important role and impact on the outcome. So from procedure to test results, when is testing ordered? I'm going to let Kim guide us through this slide and talk a little bit more about how that can look.
So Dr. Schiller mentioned in her previous slides that communication is a very important aspect of what we do for these patients in all of the steps that happen between when the procedure is completed to when the results actually get back in the oncologist's hands. So the role that I have here in the laboratory is taking those orders for the particular testing, and then how we manage, moving the specimens through that process into the testing laboratory, and then finally presenting results then to those oncologists. One of the things that we've seen is that Dr. Schiller mentioned earlier, making sure you're prepped early in the process. So having good tissue collection, having good information about fixation and those kinds of things too. But when the orders are placed reflexively at the pathologist's hands, you can certainly increase your movement of the actionable information to the oncologist, cutting down a lot of time between orders and that sort of thing. So what we see in some instances here at Path Group is that, even though that pathology-based reflexive ordering is the most timely, there are a lot of challenges that come with that. We need to have some good communication between the hospitals and the pathology facilities, making sure the utilization and those kinds of things are handled correctly. We also need to have communication with the local oncologists so that they understand the direction from the hospitals, as well as us as the middleman in that situation as the pathology services. In order to, satisfy the requests of both ends of that picture, making sure it's okay in both instances to actually get these tests ordered in a timely fashion, and what the tests are, when it's appropriate, and that sort of thing. So we're hoping that we can improve on, pathology services and automate that a little bit more in the future. It's really been a long-standing process where there are very different ways for pathologists to result different information in their particular sign out. And so we're trying to fine tune that and make that a little bit more automated. So how they result, which different diagnosis they actually present for the patients would then trigger some automation where we could then reflexively add these tests on. We also have a team here, some molecular pathology consultants that have a lot of expertise in which tests are appropriate at what times. So we've really relied on their expertise, training the other pathologists, training even the oncologists when it comes to what's necessary in which instance. And Dr. Schiller has really led that team of pathologists here at Path Group in trying to increase that education and communication. There's a process in the workflow where the pathologists that are looking at the tissue for the testing downstream have to review the H&Es. So we're trying to, like I said, automate all those processes so that initial diagnosis to order of these reflexive tests for this non-small cell lung cancer could happen within 24 hours. That's our very best case scenario, and hopefully we'll get more people to adopt that kind of workflow. Certainly, we know here in the laboratory that oncologists are sitting, you know, at offices and in their facilities waiting for that diagnosis for these patients that they're treating. And then there are different ways where they could potentially be placing the orders for this downstream testing, whether it's directly to a laboratory that performed the pathology or to another outside laboratory where they have to collect the blocks and then transport the blocks from that original pathology facility then to the testing lab. So there are a lot of different steps in the process that will add you know, turnaround time for these patients. And we're just trying to look at this globally and improving on all those steps so we can get those actionable results to the patients as quickly as possible. So the next piece of this is when the samples actually are making their way to the laboratory. So Dr. Yarmus and the previous discussion you had talked a little bit about how the sampling methods need to happen and those kinds of things. And then Dr. Schiller mentioned it a little bit earlier as well. And she's got a nice slide here coming up in a little bit that will have, it's a good visual about how that tissue needs to be placed for good sample management. And then the information about the fixatives and processing methods and that sort of thing. It's really helpful for my teams in the laboratory to have all that information so we can do good troubleshooting when there are potential failures, because that's the last thing we want to do is get this tissue, get it to us in a timely manner, and then end game, don't end up with a good result because something that fell through the cracks, ending up with any kind of a failure because of, you know, some kind of miscommunication or a problem earlier in the process. So operationally here, we get samples from outside facilities where blocks are chosen at that originating pathology facility. And then some of those facilities will either send their blocks or cut some slides. So another piece that is kind of critical for the downstream testing laboratories like FISH and molecular are that the preparation of the blocks and slides need to have some good oversight. One of the things that we stumbled over as we were troubleshooting some of the molecular and FISH, you know, problematic cases was that histology laboratories, I guess I don't want to speak for other histology laboratories, but just kind of the mindset of a histotech may be something where you get a request for 5 slides or 5 stains and then address the amount of tissue visibly in that material and then change the thickness minimally in order to get all 5 of those slides cut from that tissue. That workflow or that thought process doesn't work well for downstream FISH testing or molecular testing. FISH is expecting that the thickness be consistent on every slide that they receive from every facility, if that be the case, and then communicate, you know, if they have problems with a particular facility, how they're doing it, what the thickness is. And for the molecular testing, as the pathologists here are looking at an H&E and the number of slides cut for that particular molecular testing, EGFR in this instance for the non-small cell lung cancer, they need to understand the thickness of the amount of tissue on those slides so that they can adequately determine if there's going to be enough tissue for the downstream molecular testing. So there's a lot of pieces and parts that go into play as we are moving, stepwards down the process of sample collection into the laboratory, and then from into the laboratory all the way through to the testing group inside the laboratory.
That's such a great explanation, Kim. Slide. And, yes, because I think it might be helpful to share that we found one way for us in terms of increasing our success rate was to increase the thickness of the cuts of our slides, right?
Yes, for that molecular testing specifically. And then once we got that consistency and the number of slides that they were sending into the molecular department for that DNA extraction, then we could repeat that and had a lot better success downstream.
So there's so many nuances and there's a lot of experience. So this is the slide that Kim was describing. And so you can see in figure A, that's where both tissue fragments are put in the same block. And, you can see that each tissue fragment has a different shape. And then you can see when you look from the side view, how they're not necessarily fully in the same plane. And so this is how we can end up really starting to lose tissue quickly, especially if, let's say, the tissue fragment on the left-hand side in that side view of the A portion or top portion of the figure, say that has all the tumor, and it's really only in that very thinner, kind of more centrally placed portion. Well, how much of that will be left depending on how much you're facing the block, or maybe the tissue is all in the thinner, tumor is all in the more thin piece on the right. And when trying to just get a clean view of all of the tissue in that block, you end up losing all the tumor and your opportunity to test. So when you go and you put the specimens in separate blocks, like you see in the B portion of the diagram, you see how you can optimize, each tissue fragment for its individual change in shape and size. And even if all the tumors in block B, you would know how careful to be. But in the perfect world, we'd have tumor in both sections, and we could really spread out the tissue in terms of, for not only diagnostic confirmation of what we're dealing with for that initial diagnosis, but also for the downstream test. So it's very important. The clock is ticking. Turnaround time cannot be underemphasized, because and I'm not sure how many of you have had a family member who's had a cancer that's waiting on this information, but for them, for the patient, their family, minutes are hours, hours are days, and days are weeks. So it's very important that we're sensitive to that. And especially with lung cancer, 60 to 70% of these patients are advanced stage at the time of presentation. And there's a fair percentage of them that time is against them. So we have to try to really keep that in mind and work to decrease the gaps in terms of time. So additional other pre-analytic considerations include reviewing the H&E slides. And that's a requirement now, and you need to document how much tumor is present. It's also important to have already had a predetermined plan with the stakeholders, the providers and so on, about what to do if a specimen doesn't meet criteria. So are we going to give priority to EGFR and ALK, EGFR, ALK, and PD-L1, and then are we going to try for a small panel? If it doesn't even do that, what genes do they necessarily want right out of the blocks? And you can look at that and balance how likely it is to find a mutation, as well as how actionable that alteration would be in the therapeutic decision tree, and have those discussions. We have that established here at Baylor itself. We also have that established within Path Group, and there are, some providers and groups we work with in hospitals. They may have their own different preference, and we're able to indicate that in our laboratory information system. There's also ways to enrich for tumor. You can either just core a piece of tumor out of the block, or you can do macro dissection scraping tumor off of unstained slides, or microdissection, where you actually say, okay, knowing that necrosis is problematic or mucin's an inhibitor of these assays, trying to really circle the slide and get those extraneous variables out to really optimize when you have particularly a very mucinous tumor, for example. Nucleic acid extraction, the whole method is important, as well as the evaluation of the quantitation of the DNA, and that has to be documented as well. And as I already mentioned, fixation is important, drying time, cold ischemic time, and all these other things that happen before the specimen ever actually reaches the molecular lab for downstream testing. Finally, unstained slides do have a shelf life. Really, the long end of that is 14 days. So now we're going to move on to the analytic phase. And again, just to remind you that the clock is ticking. For the patient and the provider, the clock is ticking from the time the procedure occurred. So if it's important to keep in mind that the clock starts for the molecular lab, though. Once we actually receive the specimen, we're held to a standard based on when the specimen hits the lab for which that testing occurs. So there is a lot of stuff upstream of that that can impact turnaround time. Things to think about the originating institution. They may be things that you guys are dealing with at your institutions, is how to manage a test if it's a send out. In fact, the volume here at Baylor has reached a volume to where probably in a different financial world of healthcare, we'd have an additional full-time employee who only handles that. But because we don't, we're having to work that in with existing staff. Who receives the orders? Is there one designee to look for these orders, one recipient that all that routes through? And if not, who are the individuals? Who pulls the specimens? If you don't have reflex orders, it's possible that the block has already been put into storage, and depending on the lag time, it could be in remote storage. So who's going to be responsible for that? And then again, we have a regular work day, so how do we work that into the schedule? And if unstained slides aren't already cut, how are we going to get that done and worked into the histology lab workflow? So kind of the recommendation in the CAPAS ICAM guidelines of 2018 was to try to have send-outs completed by 3 days of the time it's requested by the provider. And again, the results we're held to in the molecular lab is a 10-day turnaround time. That's 10 calendar days for large panels. So if you sit there and think about, okay, if we take our whole 3 days to send it out, and then it's a couple days transit, and then 10 days the result, we're already at 11 to 13 days from testing alone, not including maybe the 1 or 2 days it took to get the diagnosis in a perfect world, if it's, say, a procedure on a Monday. But if it's a procedure on a Friday and it's not diagnosed, you can just start to see how all of a sudden you have this huge lag time and a patient on the other end who's not getting treatment until this information is delivered to the provider. And I can't underestimate or underemphasize how important that is. And that is why it's very important to try to narrow every window you can. And it's also important to realize that getting this testing out the door, if it's not done in-house, needs to be treated with the same level of urgency as getting that initial diagnosis, because nothing happens until this information is provided. So Cam, would you like to talk more about specimen tracking for us?
Yeah, so obviously we're all going to do our part to try to decrease the turnaround time, because we know ultimately those patients are patiently waiting for the information in order to get some kind of treatment. So the things that we track here in the laboratory are turnaround time from procedure date until the test is ordered. So we talked about that a little bit earlier. The best option there is if we have some maybe pathology reflexive orders in place where the oncologists and the hospitals or all the team members agree on when that should happen and how that should happen. It needs education, communication, and that sort of thing. But that is your best case scenario, where things could happen within 24 hours if that is the workflow that's accepted and adopted. We also then track test orders to material received in the laboratory. And like Dr. Schiller mentioned earlier too, the facilities that are sending out that material play just as an important role as the downstream, testing laboratory. So once you do get an order, try to collect that material as quickly as possible and then get it sent to the testing laboratory. And then the third piece of that is that material received in the laboratory until the results are actually analyzed and posted and signed out and then sent back to those oncologists so they can actually have those actionable, have that information in their hands to then take some action on that. So we all play important pieces in that, all three of those steps, throughout the process. And like Dr. Schiller mentioned, hopefully we all do our part and try to make things more efficient, increase communication and education, and then ultimately get those timely and high quality results to those oncologists and those patients in this non-small cell lung cancer setting.
Thank you, Kim. And so, in summary, really, time is of the essence, and we need to be sensitive to that and thinking about it. And that's all the introductory material that we have. Hopefully, we gave some helpful hints and directives. And I think at this point, I'm going to hand it back off to Dara.
Thank you so much, Dr. Schiller and Ms. Brinkley. Let's open the floor for some questions or comments. If you'd like to share a challenge you faced or a lesson learned, you can click the reactions near the bottom of your screen, select raised hand so we can call on you. Also, there have been a few questions that came in through the chat. I see one from Lynette Pinault. Might have been answered already, but the question is, she'd like to learn how testing order sets and priority are determined between pathology and oncology, if orders are placed by the pathologist or the oncologists. That may have been covered.
Okay, so yeah, there's actually a lot of questions there. So so at Baylor, it's a standing delegated order through our medical executive committee. So at our we have a bazillion, literally we have over 40 tumor conferences a month by individual site and so on, and they each have a governing committee, a few key stakeholders, for each clinical division in pathology. So we have a discussion, and then first of all, I abstain from voting. Since it's a laboratory test, I don't want to have any potential kickback accusations made of the department. So I don't ever vote, but I do provide them information about the laboratories out there and answer questions from a technical perspective about test characteristics, et cetera, and so on, cost and blah, 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 all that stuff. Then I take notes while they're talking, including things that I maybe answer questions on. And then they take a vote on what they want. And again, I abstain from that part. And then whatever has been determined, I write it up, draft it to the key person. None of the pathologists are leaders of any of these site committees, so we don't have to worry about it from that angle. And then they, make sure I didn't make any mistakes. That then goes to the medical executive committee of the cancer center, who then, either has more questions, but usually they don't. And then that goes to the medical executive committee of the hospital. So then it's an understanding. So honestly, it's kind of just happening because it was a result of that multidisciplinary dialogue. I guess technically the pathologist is ordering it or sending it along, but it's because of a multidisciplinary discussion. I think it's very important that the providers get to weigh in and say what it is they want to have. With Path Group, anytime we see someone ordering a bunch of different individual genes, given our experience in our hands, data, and multiple guidelines, we flip that to the broad genomic profile to make sure that we can optimize and get results more often on each patient. And then if we are in a tight tissue situation, but those are all either coming in from pathologists, and they're either coming to us from the pathologist based on an institutional delegated order like this, or through a discussion from an oncologist. And then we also have oncologist ordering, and that's in the Path Group realm. So that's kind of how it's working in multiple realms, and that kind of stopping the individual gene testing behavior when it's clear they're considering targeted therapy for the patient has also helped to streamline things.
Wonderful. I see that Lynette has her hand raised. Would you like to unmute yourself and go ahead, please?
Thanks, Sarah, and thanks for that description. I think that's helpful. I think we have a similar experience here. So I guess what I was wondering, I was very curious about the pathologist doing the reflex order, which is that's kind of how we would do it here in our institution as well, using that multidisciplinary team approach. But I was very curious, in our situation right now, we have an order set that's approved by oncology, and the oncologists kind of drive that and they place the orders. I think it's very interesting that you have the pathologist sending that out, reflexing on that standing agreement. And I'm just curious how you use those molecular oncologists to help drive that order set, and if those are employees of the laboratory, and if they're consultants, or are they just part of your team? Because I think that that's an opportunity that we might be able to use to make this maybe a little more efficient.
Yeah, I apologize. I didn't answer that part of the question.
No problem.
So I am a molecular pathologist. So by design, everything that has the word gene or DNA tied to it in the entire Baylor Scott and White healthcare system ends up getting emailed to me in some way, shape, or form. So in the most active dialogues in the space, right? So I'm the one that's kind of, I guess, driving it. I'm the one coming at them with the evidence-based data and all of that. But you could select within your department a spokesperson. I'm not sure how your different, tumor boards are segregated out and but you may have one or two pathologists serving on them. And I would choose the one that I feel like is more assertive, or you could have just one person kind of oversee that category of considerations. And I make the rounds for all the different other primary sites as well, but the most active dialogues in lung.
Yeah, that's really great. In our experience, we know that we have like a handful of oncologists that really understand this, and then most of them don't.
Right.
And then it's up to our staff to kind of triage what they want and what the priorities are. And we do have those systems in place. But as you know, they change all the time, and they're competing interests in what the new fancy test should be on the order set. And so maybe we just need to get a molecular pathologist to help drive that.
Yeah,
take it back, maybe.
I think, and
Wonderful.
if you guys have one, great. And if not, you can contact me offline and we can figure out how we can get some help your direction.
Yeah, I think it's that the sustainability of the process. So thank you for sharing your experience. It's great.
For sure.
Well, this is wonderful. We have a few more questions in the chat we can try to very, very briefly get to before we do our breakout rooms. Question from Wei Louis. What do you do with unused blank slides?
They get filed in with the patient's tissue, like we handle everything, and we have every single block and slide from every patient since we've had a practice. So, they wouldn't be very useful, but that they're stored with the patient's tissue.
Okay, great. And last question here from Dawood Kazaz. What impact does CMS have on this workflow, including turnaround times?
I can let Kim answer that some, and I can also answer it, but I may see it differently. I'd like to hear what Kim would say there.
The only understanding I have about that is the feedback that we get from the hospital systems about payment or, those types of things. What's recommended, what's required, what's reimbursable, different things like that. So in the business, we all have to deal with those aspects of the testing as well. So there's, a lot of different layers there as we forge forward in relationships with hospitals and the billing that has to happen for this types of testing.
Yeah, and so as we all know, the payers vary around the country and how they pay. When you're testing in the appropriate clinical setting, you should be getting paid. Now, there is also the 14-day rule consideration, but the likelihood of a patient being diagnosed inpatient with lung cancer is the exception, not the rule. Most of the time, something's been documented on some sort of imaging. Patient presents as an outpatient. They come in for a 23-hour observational procedure for a biopsy of where that diagnosis lands. So it's not common that they're diagnosed as an inpatient. When it does happen, We do make concessions when we need to, but sometimes we run the test because if they're admitted, they're often not admitted because they're healthy, and we don't always have the luxury of time. And so we just got to do what we've got to do in the best interest of the patient.
And with this grouping of tests for non-small cell lung cancer too, those 14-day rule applications come into play because the IHC and the FISH don't follow the same rule as the molecular testing. So it's something to be really cognizant about when you're having those discussions.
Well, thank you so much for questions and discussion. We will continue those discussion elements in the Facebook group, I hope. And let's continue it right now with our breakout rooms. We're going to shift into small group discussions. You might remember the reflective questions that were included in registration. What challenges and turnaround time is your AP team trying to tackle? What's working and what's not? Here's an opportunity to learn from each other, share success strategies, and refine a plan for individual growth. To support your discussions, we're providing you with guiding questions. We'll be dropping a link to a Google form with these questions in the chat once you are in the breakout room. The hope is that in your group, you will designate one person as note taker to jot down the thoughts that are shared by the group. That'll help us capture current issues in the field as well as your successes to share with others. The questions are much more than you're going to be able to address in 10 minutes, so please gravitate towards whichever you would most like to speak about during this time. You will also have access to this same Google Doc if you would like to share your ideas individually by filling out the form after the fact. We will have only 10 minutes in the group. We'll come back as a whole group, possibly have a few minutes to share highlights from discussions. And in a moment, you'll receive your prompt to enter your breakout room. When time is up, you will be redirected back to this main room. So enjoy your discussions. Okay, hopefully you had a chance to have some solid discussion in your small groups. Maybe you've become clearer on particular challenges your institution faces regarding turnaround time. We only have just brief moments for sharing out from your groups. Would anyone like to unmute yourself and share some things you were speaking about? Again, it was a very short time, and if you'd like to revisit the questions in the Google form with more reflection, I'm sure we will get a lot more of your ideas that we can share with others. Due to time, we should move into closing because we're now at the end of today's video conference. We want to thank our presenters and all of you for your participation. Please take a moment to complete the survey as you leave. We rely on your input to help shape future educational initiatives. We'd also like to invite you to save the date to upcoming video conferences. On February 15th, the state-of-the-art biomarker testing in gastrointestinal cancer, and March 31st, implementation of CAP IASLC AMP 2018 molecular testing guidelines, part of this video series. And hopefully you have ideas fresh in your mind, and if you would like to start your action plan, please visit the Resource Hub on ASCP's website or use the link to the hub, also located in the chat. You will receive an email from ASCP with links for both the survey and the hub, as well as the Google form, to start your action plan. Please check the email address you registered under. Thank you again, and this concludes today's presentation.